There, are we going? I think we are. Dr. Howlett, thanks for agreeing to do this for us in this project for Vaughn. And tell me who you are, although I just called you Dr. Howlett, and what you do and what's your role.
So I am Jessica Howlett. I'm one of the neonatologists with Sunflower Neonatology, and I have been with this group for about 8 years now.
Wow, I remember when you came. It seems
It goes by
longer than
fast.
that. Yeah. Okay, so just a little bit. So why did you decide to be a neonatologist?
I decided to become a neonatologist because my brother was a premature baby, and we lived in Northeast Iowa, and at the time my mom actually had to be flown by helicopter to Sioux Falls, South Dakota, where she delivered my brother. But I remember the aspect of having a little brother, him coming home on a home apnea monitor, which we rarely do now, but it going off all the time. And
How old were you when all that
I
happened?
was 6 years old.
So,
and staying at the Ronald McDonald House, so it has a precious place in my heart as well. And just the support. We couldn't see my brother. The closest we could get was seeing him through the glass. He was in a NICU that you still had the glass mirror, or the glass wall, windows. But you could kind of see him through there. So a few weeks of his life, we could just see him through there. And they once brought him up to us. That was back when they didn't worry about infection, I think, nearly as much as we do.
So how
now.
old is he now?
He is in his early 30s.
Okay, so you have a little history there.
Yes.
And you've been the neonatologist here for 8 years.
Mm-hmm.
And did you come here right out of training or fellowship, rather?
I did. I joined right after fellowship, and I did my training in Baltimore, Maryland. So a very different aspect. Still a very busy unit comparably.
Right. So as a neonatologist, do you work closely with perinatology and OBs?
Very closely. We are dependent on them to learn about our soon-to-be patients, and they're the ones who determine when a mom needs to be delivered, and we're the ones to help out with the baby when the process is going on.
Can you kind of walk me through a typical delivery that you would experience up here as a neonatologist from a patient delivering downstairs, sort of starting at the very beginning, the phone call you get about?
So we may or may not know about a mom, depending on what the reason brings a mom in and how far into her pregnancy she is and how active her labor may be or the other problems that lead to a delivery. And so at that time period, one of the OB staff would contact our staff, and it might be one of the nurses letting us know, or it might be one of the OB MFMs, the maternal fetal health doctors, giving us a call and letting us know that there's a patient. They would sometimes like to see us beforehand if they can, if a mom's able to, or if a mom's in active labor and they think they'll deliver the baby sooner, to get our team prepped. And
So that phone call, let's just go with that one for a moment. Okay, so it's perhaps somebody we didn't know about, like not down on antepartum for weeks and weeks, and we get a phone call. By the way, we have a lady that is, and I'm just making this up, she's 25 weeks, she just came in, she's going to deliver. How does that conversation go?
So kind of just as you said, they would give us as much information as they may know. They may say that she's 25 weeks and delivering, or she's 25 weeks and they may think she may deliver. And if they think that she's at all going to deliver, we would try to encourage our team to gather the respiratory therapists and the nurses who may go with us and have a little pre-huddle, and just to discuss what kind of support, or if we need anything else extra in the delivery room, whether it be surfactant, which is that oil of the lungs for the baby, or if we felt like we needed another nurse for another reason, because a lot of times we'll ask if there's more than one baby. There might be 2 babies, and we might need another team for that other baby too. And
So
who's
the
gonna
huddle,
go with us?
so you get the phone call that you call this huddle together, so it's going to be the charge nurse.
The charge nurse, the nurse who's going on deliveries, the doctor who's going to go to the delivery along with the nurse practitioner, and ideally the respiratory therapist.
Okay, so you all talk, chit chat real quick about this is what we're going into, and get ready, and you go down. And in the meantime, what do you think is happening up here while you're getting ready to go down to the delivery room?
What is happening in the NICU? So we're also having another group who's preparing the room. So it's still a lot of people and moving pieces, because we have to make sure that there's a room available, it's cleaned, all the isolate is available,
It's plugged in, getting warmed up.
the ventilator is available if we think a baby is tiny enough
Yeah.
to need a ventilator.
So there's the team that's going to the delivery, and then there's a small team up here just preparing for the admission, so to speak, right? Okay, so let's just go down to the delivery room. So you're all going down to the delivery room. Walk me through a delivery like that. What do you do? How's that?
So there's an OB team for the mom, and then there's our team on the side for the baby. I always like to introduce myself, if able to the mom when we first walk in, so they know who we are, and just to point out that we're the team for the baby, and we'll be taking care of their baby, and to ask them if they know if they're having a boy or girl, or if they have a name yet, because I would like to use their name if we can on their birthday. And this is still a very special day for them, very scary day for them, but a very special day for them. And to see who their support person is by them too. Sometimes they have a support person, sometimes their support person cannot make it because it's such a fast process.
Sure.
Or if a mom's been here for weeks, the other support person may have gone home or back to work and may live a few hours away. So I just like to reassure them that we are the team taking care of the baby, and that we will update them as able during the delivery room process or the resuscitation process, depending on what's going on. And then we'll try to bring their support person over to see the baby as soon as we're able to.
How do you do that?
So as soon as the baby has a good heart rate and the oxygen saturations are appropriate for the minutes of life, and we think they're on pretty stable support, that we're not having to do invasive things like chest compressions or medications, then I would be updating the family about what was going on. But we would love to bring the family, if we can bring them from the mom's head of the bed, where they're at, usually over to the bedside, so they can see their baby and take some pictures. And maybe touch their hand if that's appropriate for the baby, or
So do you ever ask the dad to come over? Like, I know you're maybe 10 feet from, you're in the same room, but you're about 10 feet away from the mom's delivery site. And as you're working on the baby, do they ever ask the dad to like motion him, come on over, you can look over shoulders as we're working on the baby and talk to him, or whoever the support person is?
Yeah, we try to as able to, and get them involved as able to, or if things aren't going well, that's when we really want to bring them over so they can be there, part of the process, and let them know what we're doing and why we're doing what we're doing.
Are they taking pictures then, or how? I've never actually been in, so I'm asking. I really don't know. It's been a very long time since I was in delivery.
So depending on if it's appropriate enough, then they can take pictures, or if they have their camera available. After, if we're just providing some CPAP and keeping the baby warm and clean, then we can have them take some pictures, or if it's appropriate that their mask may be moved to weigh the baby. Usually we weigh the baby upstairs in the NICU, but we may have them take pictures then. A lot of the pictures are usually done upstairs.
Upstairs, not so much there. Okay.
Yeah. And
so
we depending on how the baby's doing on their support, would then, if they're doing really well and we're thinking they're going to go upstairs, we may see if the mom can even hold for a few minutes. Or at least get to kind of hold by, if she's had a C-section, kind of as able to kind of by her face or see her baby.
Will this be the baby inside the transport isolate or outside?
Ideally outside, but it depends on if the baby is having a breathing tube, or if they're needing a lot of CPAP, or if their oxygen saturations or heart rate are still borderline.
So would you be holding the baby, showing? How does that? Tell me how that. Describe that in detail.
I love it when I get to. So it's a joy of mine to be able to bring a baby to their mom and show them for the first time. And
show me.
This is your beautiful baby.
Is it like this? Here's your beautiful baby girl. And
it depends on how big the baby is and how much they still could have the oxygen saturation monitor on and other things going on.
And then after the mom's been able to at least see the baby and maybe touch the baby, then you put the baby. Tell me what happens next.
Yeah, but we encourage maybe a few pictures then for those first photos if someone has a camera. And then we have a special transport isolate that the baby would then go into. And depending on if there's respiratory needs or oxygen needs, then we would keep the baby on those oxygen needs for the mom to be holding if it's the baby tolerates well. And then the baby goes in the isolate, and since we are one floor below the delivery suites are one floor below the NICU, we do have an elevator ride. So we have a special elevator just for transport, really for the babies. It only goes between the 3rd and the 4th floor. You have to have a special key, and so part of our team will go through in the elevator with the baby and ride up in the elevator. And we do encourage the support person to come up with us too, if
Okay.
they want to. Sometimes they want to stay with the mom and be with her. Sometimes they really want to be with the baby.
Okay.
And
Would
go
you
back
say?
with the baby.
Well, it's my experience has been the mothers want somebody to go with
Yes.
their baby.
Yep. Everyone wants to see where the baby's at,
Yeah,
where they're going to
yeah.
be, how they're doing, and that's where we do their head, their length, their weight usually,
Mm-hmm.
and so they can take all the
As the
pictures the
baby-
first time.
Baby's being taken up on the elevator
Mm-hmm.
to the baby's room, which is all ready.
Yep. So we have more nurses and sometimes another respiratory therapist to help out if there's more
So
than
is
one
this
baby.
the same team of nurse, or would it be the receiving team, so to speak? I don't know that that's the name we call it,
A
but
lot of time the nurse who's in the delivery room may still take over or keep the care of the baby, but you'll
Mhm.
have another team to help her out with up
When
here.
admit the baby, right?
An admission team and to help with the vitals, sometimes to help with IVs if needed,
Uh-huh.
or if we need to do lines in the umbilicus, then they will help gather the materials for that, making sure that we have the paperwork done.
Okay.
They do
So if it's
the
a-
footprints.
C-section, the mom stays downstairs, correct?
Mhm.
And there's a team taking care of her down there. And let's just say that the dad follows the baby upstairs while you're admitting.
Mhm.
Does he participate in any of that, or?
Usually he's getting updates about how the baby's doing. He'll get the updates of the weight. He might get the updates of how the oxygen saturations are doing. He's definitely welcome to be there with the baby, and if there need to be a diaper change, I'm pretty sure the nurses would allow him to help out with it. It's a little bit more chaotic, and I think that would be a great place to have parents participate that want to.
Yeah.
And sometimes it's
What
very
I-
emotional
yeah,
for the dads
It
too.
is, as you can tell. So
Mhm.
what I see, and I know this is your interview, but I see it probably more than you do because you're in working, but from
Mhm.
where I see, the dad stays in the corner, so to speak. He's looking over his shoulders as they're working on the baby, doing whatever they're doing.
Mhm.
And the nurses, and he usually, what I see is a dad that is just kind of quiet.
Mhm.
He's not asking a lot of questions. He might be taking pictures, but so what I see is the team talking to him, what they're doing,
Mhm.
where they are in this process, and if he has questions, they certainly try to answer them. But he's more of an observer, standing at the edge of the room,
Mhm.
and then what I also see, and tell me if I'm wrong, okay?
Yeah.
He'll be there for several minutes, and from the outsider, the way I describe it is it's an admission upstairs, and as I said, not in the OR, but up here it looks like organized chaos. There's a bunch of people they all know what they're doing, but if you don't know what they're doing,
Mhm. That's
they're
probably
writing
true.
things down, they're getting this, they're getting that, they all seem to know what they're doing, but if you don't know what they're doing, I've always described it as organized chaos. They all are doing,
Mhm.
I don't know, little ants, they're all doing something.
Mhm.
And that's,
bees.
yeah, bees, yeah, it's a better one,
It's
yeah,
bees.
they're all got a job and they're all doing it. And what I typically see is that they're also trying to talk to dad a little bit, giving him a little information. And then at some point, and I wish I could tell me, maybe you could help me on this,
Mhm.
10 minutes after or so, then they'll start maybe considering doing what I call the belly button line.
It usually takes probably that long because they want to do all the lengths and the measurements and
Mhm.
the weight is really the important thing too.
And that's a sterile
Sterile
field.
procedure.
And so a lot of times the dads would be encouraged to go down and check on mom.
Mhm.
Do I have the time frame right? Is it 10, 15 minutes?
Depends on each baby and depends
Yeah.
on what else is going on.
Okay.
Or if they need to do the oil to lung surfactant,
Uh-huh.
they might have to delay doing the lines to
Uh-huh.
do surfactant.
And then what happens?
Then the team would be taking care of the baby, doing the lines procedure. Those can take a little while depending on if you're waiting for x-ray or having to reposition the lines. And hopefully we would have somebody who could go down and update mom with dad, or if we can't
Who
at
is
the
that
time.
typically?
Sometimes it's a nurse, sometimes it's me, depending on what I'm doing and what my job is at that time period. Or if the baby came early enough that we're trying to scramble to get all the orders in, because without the orders we can't get the fluids.
And where would the mom be when you're going down to do this little
Usually
check-in?
she's still in the operating room.
Okay.
There's potential she may be already into the kind of the post-OR
Okay. The recovery room?
recovery. Thank you.
Recovery,
That's the word
yeah.
I'm looking for.
Okay, and so what's your top concerns about that transition time?
I think it's all the unknowns. We're scrambling to get data.
Mhm.
The families wondering about all the data, and sometimes we don't always have the updates fast enough for anyone.
Uh-huh.
We can give them the same information that we had downstairs. Usually it takes a few hours before we really have anything that's new, because the labs take a few hours to come back. It can take a while to actually get the lines in place. Not usually a few hours to get the lines in place. By the time you're fully done with everything, it can be a little while before you actually have information that's anything different.
Okay, so I'm going to give you a lot of latitude here. So let's just pretend, okay? I just had a baby. I'm in a recovery room. You've checked in my baby upstairs. Let's say I'm moderately premature. Let's say I'm 29 weeks or something, and it was a C-section. So I'm still in recovery. Kind of talk to me like I'm the mom of a baby, and you can make up the data as you want.
Okay. Hi, Miss Smith. I just went up to your baby's delivery. I was there in your delivery, and I took care of your baby. We brought your baby upstairs. He's doing well. I heard you're going to name him Derek, and congratulations. And that's very special. But I always ask families how they decide on their name. I really love asking and learning, so I may have asked that too.
I
Sorry.
named him after my brother.
After your brother.
Yeah.
That's very special. How did you decide that?
Because I get to deliver a baby, I get to name a baby. But is he breathing okay? Is there anything wrong with him?
So currently Derek's on CPAP, which is pressure to help open up the lungs, to keep your lungs nice and inflated. If you think about little balloons, that's what your lungs are, like little balloons. To help get in oxygen, out carbon dioxide, we have to keep them nice and open. And so right now he's on a little CPAP, but he's only needing 22%, which is pretty much what we breathe. And so he's not needing much more support than the air that we're breathing. But the CPAP, have you ever met anyone who's been on BiPAP at night or has sleep apnea? It's a machine similar to that it helps keep air in your lungs. And
is he going to be okay?
There's a great chance he's going to do well. We do have him on antibiotics just in case, because I know that you were in preterm labor. We worry when babies are born early, could there be infection? That's still a cause of it. We'll check out his red blood cell count, which is what carries your oxygen, and we'll check out his white blood cell count, which is your army against infection. All those labs haven't come back yet. We're still waiting on them.
When can I see him?
As soon as your team is able to bring you upstairs. So I think that's our big rate limiting step in the NICU, is that we can't determine when moms can come up because I can't bring the baby downstairs.
But you think he's going to be okay?
I'm really hopeful. Babies do really well at this stage.
Okay. All right. Thank you.
Thank you.
Do you know any other questions that a mother might ask? None of my babies are premature, so...
That's right. There's lots of them. You want to know when you can start feeding them.
Oh, okay. When will we start feeding?
That's all up to the baby, but we have a nice guideline. We tried it within a few hours of life, within the first 12 hours, and some babies we're trying to get food. And we'll encourage moms to pump if they're able to. If there's certain medications or other reasons we can't, then we do have donor breast milk for some moms.
So, in this whole process, and I know every baby's different, what would you, how could you make this process better for a parent?
Yeah, I think it is the updating as much as we're able to. It's making sure that I was thinking about this beforehand. A lot of times we won't know how long moms have been downstairs. We might just be told that a 29-weeker is delivering, and then later find out the mom's been down there for 6 weeks, but I might not know that as the doctor who came on that week, that she has been down there so long. So
Do you think that would be helpful, and when they're telling you we're going to be delivering a 29-week baby, mom's been here, you think that little piece should be added in?
That little piece would be nice and informational, and even when I'm taking care of a baby later on, months or weeks later, to know that mom had that stay that was so long. So we're not dealing with a mom who's been here for 2 months for the baby, we're dealing with a mom who's been here for 3 months.
Got it.
And so how that changes and affects a person's life is huge. If you've been trying to scramble for childcare for 3 months because you've been had 2 kids in different places, or if you've been out of your job for 3 months, that affects your financial means. Or if you live, I also like to know how many hours away a family lives, because that factors into, they're not going to be able to come except for Tuesday and Wednesday evenings.
And do you want to know that at this transition time or eventually?
Just a process, if there's ways to keep it on a board or somewhere to look that is easy for all of us as a team, just as a reminder too. Because there's certain times, yes, I can go back and look at a chart, but it's not always easy, or the face sheets aren't always correct.
Oh, yes, that's so true.
Yes, as you were well aware.
Yes.
But things that I was thinking about that are so important to the dynamics of taking care of a family. If you're living 2 hours away, or knowing if a mom's gone back to work. A lot of times the nurses may know that a mom's gone back to work, but it's trickle-down effect to when we find out.
Okay. So we're kind of focusing now just on the transition. Yes, I know that does happen after a while, but so in the process, do you feel like when you get that phone call, when you know you're going to be going to a delivery in this transition time, do you feel like in your last 8 years, pretty much you go in knowing what you need to know to be the doctor, or?
I think we're always gathering information. I never say I know everything, but I think I know enough. Even if you were just told that we have a 29-weeker, that's enough to get us through the stabilization process.
Okay.
But there's always more information that's helpful. It's always better when they say it's a 29-weeker who's been ruptured for how long, and we have the
typically, would you have that going in? If
most of the time, when we have a really good person who's
when
there
they're calling
for us.
upstairs to let us know, they give you, do they give you or the team that type of important information?
There should be. And most times when we walk in through, we should be able to have, if they're ruptured, how many babies, how many weeks, and then getting all the other information should be easy to find for us
Okay.
too.
Should the operative word there, but typically, do you think you get that information?
Typically we get it.
Okay. This is the same on the same route. Do you think that you get that important information? But I think you do.
I think we do. I think there's rare times, but there's times that they're scrambling to figure it out. We've had moms who didn't know they were pregnant and walking in, and
well, we had that today.
I know, that's exactly what I was thinking about.
But I think there's obviously many pieces of information that they don't have about family and all that stuff. But I think they knew going in
the important information.
Yeah.
One baby.
To meet that baby
not
right
yet,
where it was and do what they wanted to do. Okay, from a family's perspective, you've obviously had that in your many 8 years where somebody just came in delivery. Do you see it anything different that you have to do for a family that is coming into that transition? Something similar to that?
Can you word that again?
Okay, I guess what I see the doctor is, they're typically, and please, I don't want to put words in your mouth.
Okay.
Typically, they are focused on medically what they have to do for the baby, and all the other stuff like why this happened and where it happened, and it might be somewhat important to know, but they're just looking at a baby born at, oh, this looks like 24 weeks or 22 weeks, and they just put on that hat and start going with it and doing all the medical things that they would anticipate a 22-weeker. They're just focused on that. I don't think, are they thinking about all the other stuff that might have to contribute to that family situation?
I think we always think of all the other stuff. You had the moment when you have a 22 to 24 weeker, your first thought is, okay, let's get this baby comfortable and making sure that they're on the respiratory needs that they need, the oxygen's going well, if we can feed them, what we can feed them appropriately. But then it goes back into the social aspect too. And I, as the neonatologist, always get asked, why did this happen? Well, a lot of times we don't know.
From
families. And then of course their next question is how can they prevent this from happening again if they want to have other babies? And those are all OB questions, so we always direct them back to their OB doctors. But a lot of times we don't know why
this is the kind of question you get right after birth, or when
or sometimes even months later.
Oh, months later, okay.
I got asked this again by a family that I'd never taken care of until just recently at one of our other hospitals. And that was the first time meeting them, and their biggest thing was they want to have other kids. And they delivered at 30 weeks. And so one of the important things is making sure that they're going back to their OB doctors, that they're aware of there's certain medicines out there that sometimes moms will qualify for if they've had babies early. That's one of those is progesterone. A lot of times we don't know why. In this baby's case, there's no good reason why this mom delivered early. It was her first premature baby out of 3 kids. And I know that she was struggling with that. And so just listening to her concerns and being there and as an advocate of telling her that there's many reasons why babies deliver, and a lot of times we don't know. And her baby was doing well, but yet they were still 7 weeks into the NICU stay, and it was hard to be there still.
So in a transition time from from antepartum delivery to NICU in that time, what do you think we do well?
I think we have a really good team approach, that we still have a really good team there for not only the baby, but I think we are there for the family. And there are times where the dad might be in the corner that we can encourage them to be a part of more, as dads are able to. And I think understanding the cues of some dads are ready to be there, and some dads are taking it all in too. And I think if you would have asked my husband with our first child to get in there and do something, I think about him a lot. He failed our first hospital tour of our first pregnancy and almost fainted. And so I think if you would have asked him to do a lot the first child, we had subsequently 3 other babies, 2 came at the same time, but NICU stays too. He could do a lot more by the end, and was willing to do a lot more, and much more comfortable with the situation. But definitely, if you would have asked our first and only kid to come home with us, to do any of the things that you would have asked him to do the other kids, or seen the other kids, I think we would have been picking him up off the floor. So I think that trying to guide and see what dads are wanting to at that time period is probably important as well.
So you would just kind of judge the dad as the situation arose.
Yes,
kind of thing.
and a lot of times I might not have a big role if I'm not putting in lines, or if someone else is putting in the fluids, to be there and talk with the dad, or I may walk back down with the dad to make sure he gets back to the place he needs to, and take on that role for the team if the charge nurse is doing something else, because we try to have someone come back down with them to find where to go, and then I can update the mom too.
Okay.
But it all depends on what else is going on in the unit. And
so you feel like that goes pretty well for the most part?
I think it does for the most part. I think it's improved over the 8 years that I've been
here. Oh,
here.
you do? Okay, good.
And I think that we've made it a bigger improvement to try to be down there more timely. There's definitely times where it's very hard to leave this area, and that one floor is very far.
It is, you're right. It seems a long way, doesn't it?
Yeah, and it's hard to leave that bedside, or if things are going on. It's very difficult to even move a few feet down the hallway.
Yeah, and as you just said, all dads are different. Some really want to be included in the whole process as much as possible, and some are just really, some are quite terrified actually, the way I see it.
And some can update family members easily, and some flounder with what we just told them.
So there's no cookie mold. It's not everyone's going to be treated this way. It's kind of what presents, kind of address, kind of thing.
Yeah.
Is there anything you'd like to add to keeping it focused to this transition time? You know, things that we talked about, what we think we did well, and we talked about things that we could improve upon.
Yeah.
Anything else you can think of right now for that time frame?
I didn't think of.
Okay.
Thank you for.
Well, thank you for participating in this. We appreciate it.